It's a pleasure for me to be here this morning and to share with you some of the applications that are new in detecting lung cancer. So effectively, Dr. Kurian showed you this information, which are the American Cancer Society estimates for new cases of cancer and estimated deaths from cancer in 2015. And as she's already told you, unfortunately, lung cancer is a very, very important health problem in this country and worldwide. As you look at this schematic, you can see that lung cancer is the second most common malignancy in men. It is, as it is in women, accounting for 220,000 new cases per year. And in both sexes, it is the leading cause of cancer-related mortality, accounting for 160,000 deaths. So as you've heard, giant health problem both in this nation and worldwide. When we look at lung cancer, we can see that in men, it is the leading cause and exceeds the total from the next 3 lung cancers. In women, it is the leading cause of death and exceeds the causes of death related to either breast cancer or colon and rectum. The difficulty for decreasing mortality from lung cancer has been our difficulty to identify this at an early stage, at which point it is treatable and curable. So up to this point, we have used in patients without symptoms chest radiographs. How many folks in the audience have ever had a chest radiograph taken? So a number of you. And chest radiographs are attractive for many reasons. It is readily accessible. It is relatively cheap. It is associated with a low radiation dose. So when we get a chest x-ray, it's essentially the same radiation that we receive when we take a flight from San Francisco to New York. So very low radiation dose. The difficulty when we use chest x-rays to try to detect a mortal disease such as lung cancer at an early stage is, unfortunately, it is ineffective. And these trials have been done 30, 40 years ago, screened tens of thousands of patients using chest x-rays versus no chest x-ray. And what they found is screening with chest x-rays doesn't work. The death rate associated with screening with chest x-rays and leaving folks alone was the same. And this is the reason. So as you look at this chest x-ray, I know that you folks are not trained to look at chest x-rays, but obviously here's the heart, these are the lungs, and there is a lung cancer hidden on this image. Some folks with more sophisticated eyes are showing me that is in fact in the right lung, and let me show you with these arrows. So that is the lung cancer in this patient's right upper lobe. Now that's very difficult to see. And what was found in the screening trials that enrolled tens of thousands of patients is in order for even trained observers, such as a radiologist, such as someone like myself, it needs to reach an average size of 2.5 centimeters. It's relatively big. Unfortunately, when lesions reach this size, they can be quite advanced in stage, which means it may have spread to the lymph nodes, it may have spread to distant parts of the body. Now we look at this chest x-ray and we appreciate, well, it may be relatively difficult, but look at the corresponding CT scan or the so-called CAT scan. This is a technology called computed tomography, and the beauty of computed tomography is it lays the anatomy out so that we minimize the superimposition of structures and we can see the lung cancer very easily. The difficulty with computed tomography is it is a much more expensive modality and is associated with a greater radiation dose. And I'm going to be talking about radiation in particular as we proceed on in the talk. Because there had been no modality, no way for us to find early lung cancers in patients who were asymptomatic. I would say it was really an astonishing event in November of 2010 when the National Cancer Institute made a relatively dramatic announcement saying they were going to prematurely close the National Lung Screening Trial. And the reason they were going to prematurely close this trial was because it had reached its endpoint. And that was effectively that it showed that low-dose CT, low-dose CAT scan, could reduce lung cancer-specific mortality by 20%. That was what the trial was designed to do. And because it reached that endpoint, they said it is no longer ethical that we continue with the trial because we have shown that people who are screened with CAT scan do better than patients who are screened with chest x-rays. That was the design of the study. So the National Lung Screening Trial, it was a prospective randomized trial of over 50,000 patients. It enrolled high-risk individuals. And high risk, I mean folks who were 55 to 74 years of age, who had an extensive smoking history, 30-pack year, so 20 cigarettes a day is considered one pack, and then multiply that by the number of years. So a 30-pack year smoking history. And these individuals who were enrolled either had to be current smokers, they were still smoking, or if they had quit smoking, they had quit smoking less than 15 years to the point they entered into the trial. And these individuals were screened annually for 3 years, and they were followed for a period of time. And so there were two groups, as I've said, one that underwent low-dose CT, one that underwent chest X-ray, and then this was the endpoint that, in fact, low-dose CT had the promise of actually reducing lung cancer-specific mortality in this high-risk population. So as with many things, it takes some time to go from science to medical practice. And so this year, January of 2015, the U.S. Preventative Services Task Force, which is a governmental agency composed of experts in preventive care, issued a grade B recommendation for low-dose CT screening, which the grade B recommendation means that they felt, this group of experts felt, that there was a high probability that folks would benefit from undergoing screening. So there would be more benefit than harm in individuals, these so-called high-risk individuals, if they underwent low-dose CT. And then because of the Affordable Care Act, any recommendation from the U.S. Preventative Task Force that gets grade A or B grade will enable or will require private insurers to cover this preventive health service without copay. So this is now available for folks who fit the high-risk profile. And then similarly in March, very recently, the CMS, which is the body governing Medicare, issued the decision that they will also cover low-dose CT screening for Medicare beneficiaries at high risk. So as of March this year, eligible individuals who fit that high-risk group can undergo low-dose CT. I think it's worthwhile just to look at how effective low-dose CT as compared to other preventative health measures that we have employed for some time in the United States. And so the number needed to screen is essentially the number of individuals who would have to undergo the screening regimen in order to prevent one death. And so as you look at this table, you can see that it would take 320 patients who undergo CT screening to prevent one cancer-related death. It would require many more patients undergoing either mammography or flexible sigmoidoscopy. And then how many of you have undergone a CT scan? So I think for many of you, you're familiar with this. This is a CT scanner or a CAT scanner. Essentially, it consists of this donut, and an individual would lie on this table, and the table translates into the scanner, and the scanner is rotating like this. There's an X-ray source, there's a detector, and it's rotating around this patient. So that's why it's called a spiral CT. When I first started training in radiology 20 years ago, it would take 30 minutes to acquire a CT scan. Does anybody have any idea with the changes in technology, how long it takes now to acquire one CT scan of the thorax, which is typically around 30 centimeters in length. So when I was a resident, as I said, it took 30 minutes, 1 minute per station. And now, with these spiral scanners, anybody want to take a guess? 5 minutes, 2 minutes, 1 minute. You're close. You're an order of magnitude off. It is usually 3 to 7 seconds. Okay, that is how fast it is now. So the table is moving, the gantry is rotating, and it's basically a 7-second examination. It takes the computer much longer to reconstruct the approximately 1,000 images that comes from this study, but it's a very, very fast study. All right, let's talk a little bit about the benefit and harms associated with low-dose CT. As with any medical intervention, the reason that a physician would recommend a study is because it is believed that the patient would have more benefit than harm. And that's the basis by which the U.S. Preventative Task Force made their Grade B recommendation. The benefit of undergoing a low-dose CT if one is a high-risk individual is obviously that if, in fact, there is a lung cancer, early detection can potentially find this at an earlier stage and allow the patient to be cured. And so this idea that potential cure and reduction of death. And that's obviously a very compelling message. But there are also harms associated with undergoing a CT scan. And we're going to go over the most important ones. And these include false positives, the presence of incidental findings, the possibility of overdiagnosis, and then obviously exposure to radiation. So let's talk about false positives. So for any individual who undergoes a low-dose CT, 1 in 6 studies will be positive. A radiologist sees a finding on the CT scan that can potentially be cancer. And in that setting, then obviously the patient needs to have follow-up studies. It's important to realize that if anybody undergoes a low-dose CT and there is a finding, greater than 95% of those so-called positive studies will eventually prove to have benign disease, and it is only a very small proportion, approximately 5% of individuals, who eventually found to have cancer. Now, the way that we differentiate between what is benign versus what is potentially cancer is we usually use follow-up imaging. So that person needs to come back, say, in 6 months for an additional CT scan, in a year for an additional CT scan. And we, as physicians, will reserve invasive procedures, such as the patient undergoing a bronchoscopy, such as the patient undergoing a biopsy, only in those situations in which we think there's a very high likelihood the patient has cancer. And obviously, we recommend these more invasive procedures because we want to catch that cancer early. Now, I promise this is the only very complicated table that I will show, but these are effectively the results of the NLST, and let me just take you through this table. Essentially, here, of those 25,000 patients who were screened, here are the number of false positives at the 3 points in time that they were scanned, T0, T1, and T2. And so the numbers of cancers performed, you'll see that in brackets are the percentage of patients who had positive studies who are eventually proven to have cancer. And as I've said, it ranges somewhere on the order of 2.5% to 5% of patients will eventually be proven to have cancer. Follow-up studies in anybody who has a positive study need to occur. And what I really want to point out is in the vast majority of cases, an imaging test is what is done in the setting of a positive study. More invasive procedures, biopsies, bronchoscopies, surgical procedures are only done in cases where there's a very high likelihood there is malignancy. And based upon this type of workup, you can appreciate that patients with benign disease have a less than 0.1% likelihood of having a complication, whereas complication rates in patients who had cancer were much higher, on the order of 10%. And again, this is logical because if a patient has a cancer, they will undergo a surgery. A surgery is a more invasive procedure, and it's not surprising they have a complication. Let's talk a little about incidental findings. What was defined to be clinically incidental, significant incidental findings were found somewhere on the order of 7% of these individuals who underwent screening in the NLST trial. The most common were emphysema, which is a destructive process in the lung that occurs related to smoking. Coronary artery calcification, which is a sign of early coronary artery disease, again, a risk factor for developing this disease is smoking. Airways problems, again related to smoking, and then fibrotic lung disease, where the lung becomes scarred up, can occur in patients with no risk factors, occurs more frequently in patients with smoking. And then what was also found is in these individuals other malignancies, the two most common being thyroid and kidney. I want to talk a little bit about overdiagnosis. This is an area that was very concerning to the medical community, that we would be overdiagnosing cancers in patients who would be screened. And basically, overdiagnosis relates to a phenomena where screening, because we're looking, detects cancers that would not be otherwise clinically apparent and are not clinically important in the respect that these cancers would not cause symptoms and would not cause death. And so overdiagnosis can occur in two settings. We find, in fact, a cancer that is very indolent and would never contribute to or damage a patient's health, or we can find an important cancer, but in someone who has a serious underlying medical condition. So, for example, if we found a cancer in an individual, but that individual 6 months later dies of a heart attack, it probably is not important that we found that cancer. And so overdiagnosis is estimated to occur somewhere on the order of 10 to 12% of CT detected cancers. And so let me just show you this case that I think is kind of illustrative of the principles of overdiagnosis. This is a CT scan of a patient who has very severe emphysema, which, as I've told you, is a destructive process of the lung that is related to smoking. I'll draw your attention to this rounded coin lesion in the right upper lobe. This is called a nodule. It is a nodule that is ground glass in attenuation. By that, I mean that the density of this lesion is kind of like the glazed glass that we see periodically. That's why we call it ground glass. When we see these types of abnormalities, usually they are cancers, but they are indolent cancers. And so in this particular individual, this is when we first saw this individual for consideration of lung transplantation at Stanford. And 8 years ago, we now see that the cancer, which went from an indolent appearing tumor to this, which is more solid, it has these linear radiations that we call spiculation. So this went from an indolent cancer to an aggressive cancer. Recognize it took 8 years to undergo this evolution. So if at any point in time this woman had died of her underlying disease, her emphysema, this cancer would not have been clinically relevant. This would have been considered an overdiagnosed cancer. However, what happened is she came to Stanford, she was evaluated for transplantation, and you can see the left lung now looks relatively normal compared to the very abnormal, very lucent, very black right lung, the diseased lung with emphysema. And so she has survived the 8 years because she underwent transplantation, and she's doing very well. But now this cancer is more aggressive, and she requires treatment for this. And in fact, this woman underwent treatment for this cancer, and so this is no longer considered an overdiagnosed, overtreated cancer. But again, if we go back, if she had been treated at this point, and she had died 2 years subsequent because of her emphysema, that would be considered, in the parlance of screening trials, an overdiagnosed cancer. Okay, let's talk a little bit about radiation exposure. I think for folks who should elect to undergo low-dose CT, it's important to know that we perform these studies at very low dose, as low as we need in order to see the pertinent abnormalities, which are potentially early lung cancers. And the dose associated with a low-dose CT, and these are obviously just numbers, 0.61 to 1.5 millisievert, it's usually on the order of 3 times less than a diagnostic CT. And just as for context, I give you what is the usual radiation dose, the average annual radiation dose that we receive just living in the United States, which is 3.1 millisieverts. So you can see a low-dose CT is about half the dose of just living in the United States. If you live in Denver, where it's mile high, they have greater cosmic radiation, and they have a higher than the usual annual background, and in fact it's 1.5 millisieverts. So living in Denver for 1 year is the same dose as undergoing a low-dose CT scan. And then just as a point of reference, Currently, we are operating under the linear no-threshold model of oncogenesis related to radiation, which is that the risk of a cancer being induced by radiation is dependent upon the age and the cumulative dose. And radiation has much more significant effects on young children, and it becomes more important as a person undergoes multiple examinations. If we follow the current guidelines, which I'm going to talk about, the estimated likelihood of a radiation-induced cancer undergoing a low-dose CT regimen is less than 1%. Now, who is the eligible high-risk population covered by the payers? They are, as we've said, current or former smokers who have had a 30-pack-year smoking history, and then dependent upon the insurance plan, 55 to 80 years if one is covered by private insurance, 55 to 77 years for Medicare beneficiaries. If they have stopped smoking, they have stopped within the past 15 years, and as with any screening procedure, we're looking at asymptomatic individuals. So, for example, if someone has coughed up some blood, if somebody's lost 30 pounds within the last 4 months, that would not be considered asymptomatic. Now, I thought it would be helpful for you just to look at what are patient risk prediction models. So NLST enrolled this high-risk patient population. It is well recognized as people have looked at participants of screening trials that there are different levels of risk. And I thought it would be worthwhile just to look at what contributes to risk. Age obviously contributes to risk. The older, the higher the likelihood of a cancer developing. Education, interestingly, contributes to risk. The higher the education level, the lower the risk. Weight and being obese is actually protective for lung cancer. If one has a disease in the lung, COPD, emphysema, or chronic bronchitis related to the effects of smoking, that contributes to risk. Personal and family history will increase risk. And then ethnicity is another variant probably related to genetics that will vary the risk. And then probably the most important thing is the smoking history. Whether they are a current smoker, how much did they smoke, how long did they smoke. The one thing that I want you to note here is that gender does not, it's somewhat controversial, but it is believed that there are no differences between men and women who smoke. They are equally at risk for developing lung cancer. So what do we do at Stanford? Lung cancer screening is currently a physician-referred examination. It's extraordinarily benefit when people think about potentially undergoing lung cancer, or if a physician thinks the patient may benefit from lung cancer, there be an active discussion, so-called shared decision-making, as to whether this is something that the patient would benefit from. As I've told you, it's currently a covered preventive health service. In fact, at Stanford, we are in the process of recruiting patients for participation in research trials, because we understand that a 1 in 6 positive, with 95% of those individuals having benign disease, is not a great screening test, and we'd like to be able to predict either a higher risk group or patients who, after they get a positive study, that we can more definitively say whether the patient has benign disease or in fact a malignancy. And we're doing this looking at whether there are certain markers in blood, so-called biomarkers, that can help us. And then for any folks who are interested, I provide 2 online educational resources that are available. There's a Should I Screen, which goes into all the risks and benefits associated with lung cancer screening. And then at Stanford, several years ago, we created a series of YouTube videos called CT Scan at Stanford. There's parts 1 and 2. It was created following an individual, a very brave individual named Sarah Wykes, who is a writer at Stanford who decided to undergo this study, and she shares her journey through the screening, through going through the screening process. It's a very thoughtful video. Let me just finish by talking about lung cancer in non-smokers. So we've talked about smoking-related cancer, and that accounts for probably 85% of the lung cancers we see in the US. However, Worldwide, it is estimated that 25% of lung cancer occur in non-smokers. And this is particularly an important phenomena that occurs in Asia, where it is seen in young women at a younger age. And by far the most common histology is adenocarcinoma. And it's thought that the causative factors that may contribute to this include, obviously, some genetic susceptibility, as you've already heard from Dr. Kurian, but there are also environmental tobacco smoke. They may be secondhand smokers. And then there may be carcinogens from combustion products, from cooking and heating fuel and fumes that are used particularly indoors. So unfortunately, we cannot identify a high enough risk group in this patient population, these non-smokers, that low-dose CT is being recommended to detect disease early in this patient population. But it is recognized as a phenomena, and there are multiple trials now, particularly in Asia, looking at whether they can identify specific genetics that will allow us to identify high-risk groups. So thank you very much for your attention.